Welcome back to the Deep Dive. Today we are shifting gears pretty significantly. We aren't just browsing through interesting medical journals or talking about the latest health fads.
Yeah.
We are simulating a high-stakes environment. I am putting myself in the shoes of a postgraduate student right now, specifically someone staring down the barrel of the MD anesthesiology exams, targeting the Gujarat University board patterns.
And I'm on the other side of the table.
And I have brought you in because, well, you're the senior faculty. You're the one who has sat on the other side of the table holding the red pen.
That is right. And I'll tell you right now, today isn't about casual chatting or, infotainment. We are preparing for war.
Right.
The topic on the table is the definitive make or break question. If you fail this in the Viva or the theory paper, you don't just lose a few marks, you essentially fail the exam. We are talking about intracranial pressure ICP dynamics, physiology, and clinical management.
It really is the bread and butter of neuroanesthesia. So the mission for this deep dive is clear. We need to construct the perfect 20-mark long answer, and we need to be ready for that dreaded hot seat in the Viva station when the examiner hands us a waveform chart and simply asks, what is going on here?
Exactly. We need to move beyond just reciting facts. We need to know how to present them in a way that screams consultant material. You need to demonstrate that you understand the why, not just the what.
Okay.
So let's start where every good answer starts, the definition and exam framing. If I'm the external examiner and I look over my glasses at you and ask, candidate, define intracranial pressure, do not just tell me it's pressure inside the head.
No, that's undergraduate level.
It is. It's not enough.
Right. I've gone through Miller, Morgan, and the standard text to get this precise. The formal exam-ready definition is that ICP is the supratentorial cerebrospinal fluid, or CSF, pressure measured in the lateral ventricles or the subarachnoid space relative to atmospheric pressure.
Perfect. Supratentorial and relative to atmospheric pressure are the key phrases there. You miss supratentorial, you're technically ignoring the compartmentalization of the brain. Now, hit me with the numbers. Examiners love precise normal values.
Okay, so for the healthy adult in the supine position, we're looking at 5 to 15 millimeters of mercury.
Right.
Some sources are a bit stricter, saying anything less than 15 is safe.
Yeah.
But, generally 5 to 15 is the accepted range.
And the pediatric population, don't forget them. You never know if your examiner is a pediatric anesthetist.
True. It trends lower. Young children are usually 3 to 7 millimeters of mercury.
Okay.
And for term infants, it's even lower, about 1.5 to 6 millimeters of mercury.
Good. Now, clinically, and for the exam, where's the danger zone? At what point do we stop calling it high normal and start calling it intracranial hypertension?
Generally, a sustained pressure greater than 20 millimeters of mercury is considered pathological. I know some guidelines, like from the Brain Trauma Foundation, might suggest treating at 25. But 20, that seems to be the universal cutoff for defining hypertension in an exam setting.
Precisely. 20 is the threshold. And briefly, before we get into the heavy mechanics, why do we care? Why is that number 20 so critical? Why not 30?
Well, it all comes down to perfusion. We monitor ICP primarily to calculate the cerebral perfusion pressure, or CPP. If ICP goes up, CPP goes down, and we risk ischemic injury. Plus, there's the mechanical risk of herniation physically shifting the brain tissue against the rigid skull.
Correct. The examiner wants to hear the phrase secondary brain injury prevention. That is the clinical goal. We aren't treating a number, we are preventing secondary injury.
Right.
And keep in mind the exam pattern. This topic is versatile. It can be a full 20-mark physiology question like, describe the dynamics of ICP, or it can be short notes on Lundberg waves or the Cushing reflex. You have to be ready for all of it.
Understood. So let's move to section 2. This is arguably the most high-yield theory part. If you get a question on ICP, you must mention the container.
A container, yes.
Talk to me about the closed box concept.
This is fundamental. We are dealing with the cranium. After the fontanelles close, usually by age 2, the skull becomes a rigid, non-distensible container. It doesn't expand. It's a fixed volume box.
And inside that box, we have the intracranial contents.
Correct. We break them down into 3 specific components. What are they and what are their volumes?
Okay, first, the brain tissue itself, the parenchyma. That's the bulk of it, about 80% of the volume. In an adult, that's roughly 1,400 grams or 1,400 milliliters.
Good.
Second is blood, about 10%, or roughly 150 milliliters, which is split between the arterial and venous sides. And third is the cerebrospinal fluid, or CSF, which is the remaining 10%, also roughly 150 milliliters.
Right, and it's important to note that the CSF is split. About half is in the skull and the other half is down in the spinal canal.
Ah,
Now, for the Viva, you need to state the Munro-Kellie doctrine clearly. Don't paraphrase it too loosely.
the Munro-Kellie doctrine states that because the total volume of the skull is fixed, the sum of the volumes of these three components, brain, blood, and CSF, must remain constant.
And the implication, what does that actually mean?
The implication is a zero-sum game. If you develop a hematoma or a tumor or swelling, you are adding new volume. That new volume must be offset by a decrease in one of the other components. If you can't decrease something else, the pressure of the ICP will rise.
Exactly. Now, the brain is smart. It has compensatory mechanisms. We call this the squeeze. What gets squeezed out first?
The first line of defense is the CSF. We can translocate CSF from the cranial vault down into the spinal subarachnoid space. Basically, you squeeze it out of the head and down the spine.
Right.
We can also increase absorption of CSF into the venous system via the arachnoid villi.
Correct. That's the easiest volume to move. It's the most compliant. And if that's not enough, what's next?
Then we go to the second line, blood, specifically venous blood. The body tries to extrude venous blood out of the skull into the extracranial veins, like the jugular system.
Why venous and not arterial?
Well, the arterial side is a high-pressure system. It's hard to squeeze. But the venous side is low pressure. It's compressible.
But there is a limit, isn't there?
Absolutely. The brain tissue itself is essentially non-compressible. You can't squeeze neurons without killing them. So once you've squeezed out as much CSF and venous blood as possible, you hit a wall. Any further increase in volume causes a massive spike in pressure.
Which brings us perfectly to Section 3, intracranial compliance and elastance. This is the core of the physics. Examiners love to ask the difference between these two words, and students often mix them up.
Okay, let's unpack this because it's crucial. Compliance is the give. It's the change in volume per unit change in pressure delta V over delta P. It represents how distensible the system is. It's the buffering capacity.
And elastance.
Elastance is the opposite. It's the inverse of compliance. It represents the stiffness of the system. Mathematically, it's delta P over delta V. The change in pressure for a given change in volume.
So if I ask you to draw a graph, and I will ask you to draw a graph in the written paper, what does the intracranial pressure volume curve look like?
Okay, I'm drawing a graph with volume on the x-axis and pressure on the y-axis. The curve isn't a straight line. It looks like a hockey stick or an exponential curve.
A hockey stick. I like that. Walk us through the phases of that hockey stick.
Phase 1 is the flat part of the stick. This is the compensated phase. Here, compliance is high. You can add a fair amount of volume, say a slowly growing meningioma, and the pressure barely moves because we are successfully squeezing out CSF and blood. The system is compliant.
It's buffering the change.
Exactly. Then what happens?
Then we hit the knee of the curve, phase 2. The compensatory reserves are running low. Compliance begins to fall. We are running out of room. The curve starts to bend upward.
And phase 3.
Phase 3 is the vertical rise. This is the decompensated phase. The curve goes almost straight up. At this point, compliance is effectively 0 and elastance is maximal.
Right.
And even a tiny increase in volume, like a cough, a bit of suctioning, or a small spike in blood pressure, causes a massive, dangerous spike in ICP.
That is the key clinical takeaway. High elastance means a stiff brain. The patient is living on the precipice.
Exactly. If you have a patient in phase 3, you cannot afford to let them cough on the ventilator. You cannot afford a 5 mmHg spike in PACO 2. It could be fatal. That's why we care about the physics. It dictates our gentleness in the ICU.
That leads us neatly to Section 4, the determinants of ICP. We talked about the three components, blood, CSF, and brain. Let's break down what actually changes their volumes clinically.
Good idea.
Let's start with cerebral blood volume, or CBV, because that feels like the one we as anesthetists mess with the most.
It is. It's the most dynamic component.
Yeah.
What changes CBV?
It's mostly about the diameter of the vessels, vasodilation versus vasoconstriction. The biggest driver is CO2. Hypercarbia high CO2 causes vasodilation, which increases blood volume and raises ICP.
And hypocarbia.
Does the opposite. It constricts vessels, reduces CBV.
And what about our drugs? This is our daily toolbox.
Volidalsthetics, SIVO, ISO, DASARs are all vasodilators. They uncouple flow and metabolism. They increase CBV. On the other hand, intravenous agents like thiopentone and propofol are generally vasoconstrictors. They reduce CBV and ICP.
Don't forget the venous side. We often focus on the arteries, but the drain matters just as much.
Right, obstruction to venous outflow. If the patient's head is turned, compressing the jugular, or if PEEP-positive end expiratory pressure is high, raising intrathoracic pressure.
What does that do?
Well, it backs up blood into the brain and raises CBV. It's plumbing. If the drain is clogged, the sink overflows.
Perfect analogy.
Okay.
Okay, next component, CSF. We know there's about 150 milliliter total. How does its volume change?
Well, production is fairly constant, about 0.35 milliliters per minute or 500 milliliters a day. It's like a constant drip from the choroid plexus.
Does production care about ICP?
Not really, it just keeps pumping regardless of the pressure.
But absorption does care.
Yes, absorption happens at the arachnoid villi. It is linearly related to ICP. The higher the pressure, the more is forced out, up to a point.
And when does that fail?
If the villi gets blocked by blood-like in a subarachnoid hemorrhage or overwhelmed by debris or infection, you get hydrocephalus because the drain is plugged, but the tap is still running.
Here, finally, brain tissue volume.
This increases with space-occupying lesions, tumors, hematomas, abscesses, or edema. We have cytotoxic edema from cellular swelling and ischemia, or vasogenic edema from blood-brain barrier disruption in tumors or trauma.
Excellent. And we are entering the very high yield zone, section 5, ICP dynamics and waveforms. If you are in a Viva and they hand you a trace, you need to identify the 3 peaks. This is a classic hot seat question.
Okay, so a normal ICP waveform is pulsatile. It corresponds to the heartbeat. You see 3 distinct waves, P1, P2, and P3.
Let's break them down. P1, what is it?
P1 is the percussion wave. It's the first sharp peak. It originates from the pulsation of the choroid plexus, transmitting the arterial systole. It usually correlates with the arterial pulse. It's the entry of blood into the head.
P2, this is the crucial one.
P2 is the tidal wave or elastance wave. This is the most important one for us. It reflects the brain tissue compliance.
Explain.
It's like the echo bouncing off the brain parenchyma. If the brain is soft and compliant, the echo is small. If the brain is stiff and non-compliant, the echo is loud. P2 gets bigger.
Good. And P3?
P3 is the dicrotic wave. It correlates with the closure of the aortic valve, the dicrotic notch.
Now, here is the Viva trap. How do you tell a compliant brain from a non-compliant brain just by looking at the P1 and P2 relationship?
In a normal, healthy brain, it looks like a descending staircase. P1 is the tallest, then P2, then P3. P1 is greater than P2, which is greater than P3.
And in a tight, stiff brain?
The pattern changes. As compliance decreases, P2 starts to rise. It becomes taller than P1. The waveform looks rounded or elevated in the middle.
And if P2 is higher than P1, what does that mean?
It's a flashing red warning sign. It means intracranial compliance is poor and the brain is stiff. Even if the absolute number is only 18 mmHg, if P2 is higher than P1, that patient is in trouble.
Precisely. P2 dominance is a hallmark of raised ICP. If you see that on a monitor, you need to act.
Okay.
Now, apart from the individual pulse waves, we have slower pathological trends called Lundberg waves. Walk me through A, B, and C.
Okay, Lundberg A waves are the scary ones. They're also called plateau waves.
And what are they?
This is a sudden, massive rise in ICP to 50 or even 100 millimeters of mercury. It lasts for 5 to 20 minutes.
What does an A wave tell you?
It's an ominous sign. It indicates critical ischemia and a completely exhausted compliance. It's often triggered by a tiny stimulus like suctioning in a vulnerable patient. It basically heralds imminent herniation.
Right. And B waves?
B waves are rhythmic oscillations occurring every 1 to 2 minutes. They spike up to about 50 mmHg. They're often linked to unstable respiration or Cheyne-Stokes breathing.
So not as bad as A waves.
Not as immediately fatal, no. But they suggest the system is unstable and compliance is failing.
And C waves?
C waves are rapid, low amplitude, about 4 to 8 per minute. They relate to blood pressure oscillations, the Traub-Herring-Mayer waves. They're generally considered less clinically significant compared to A and B.
Good. So A waves are the emergency. P2 higher than P1 is the warning. Now let's talk about the math that saves lives. Section 6, the relationship between ICP, MAP, and CPP.
This is the formula everyone must memorize. Cerebral perfusion pressure, CPP, equals mean arterial pressure, MAP minus intracranial pressure, ICP.
Is there any nuance to that anytime that formula is not quite right?
Yes, technically it's the inflow pressure minus the outflow pressure. Usually ICP is the outflow pressure. But if the central venous pressure, or CVP, is significantly higher than the ICP, which is rare, but possible,
Then what happens?
then the formula becomes MAP minus CDP. It acts like a Starling resistor. The flow is determined by whichever downstream pressure is highest.
Correct. That's a distinction level detail. But for 99% of exam questions, you use MAP minus ICP. So what are our targets?
Normal CPP is around 80 mmHg. In traumatic brain injury, or TBI, the guidelines like the Brain Trauma Foundation suggest targeting between 60 and 70 mmHg.
Why not higher? Why not drive it to 90 or 100?
Oh, more is better, right?
Not necessarily, because aggressive fluid loading and vasopressors to hit high targets can cause ARDS, heart failure, and other systemic complications. We just need enough to perfuse. We aren't trying to supercharge the brain, we're just trying to keep it alive.
Good. And what are the danger levels for CPP?
Below 50 mmHg, you start seeing EEG slowing. Between 25 and 40, the EEG goes flat. Below 25 mmHg, you have irreversible neuronal damage.
This brings us to autoregulation. Explain the curve.
The brain is amazing at maintaining constant flow. Between an MAP of roughly 50 and 150 mmHg, cerebral blood flow, or CBF, stays constant at about 50 milliliters per 100 grams per minute.
The vessels dilate if BP falls to maintain flow, and constrict if BP rises to limit flow.
And what happens in chronic hypertension? Does that change things?
Yes, the curve shifts to the right. These patients are physiologically used to higher pressures. If you drop their BP to normal levels, say a MAP 60, they might actually be ischemic because their lower limit of autoregulation has shifted up to 70 or 80.
And what happens when ICP is raised? This is the mechanism of the death spiral.
This leads to the vasodilatory cascade.
Right.
So raised ICP lowers the CPP.
Right.
The brain senses low perfusion, so autoregulation kicks in and dilates the vessels to get more flow. But dilation increases cerebral blood volume, which raises ICP further, which lowers CPP further. It's a vicious cycle.
Exactly. That is why we must break the cycle. Now, Section 7 covers the causes. For an exam answer, you need to categorize these. Do not just list them randomly. Structure is everything.
Right. I'd group them into 4 categories. First, mass lesions.
Such as
Hematomas, epidural, subdural, intracerebral, tumors, abscesses.
Yeah.
Second, generalized swelling or edema. This includes vasogenic edema from tumor breakdown, cytotoxic edema from ischemia, or interstitial edema from hydrocephalus.
Okay, third.
Third, vascular issues, anything increasing blood volume, hypercarbia causing vasodilation, venous sinus thrombosis preventing outflow, or malignant hypertension breaking through autoregulation.
And fourth.
Fourth, CSF issues, obstructive hydrocephalus where flow is blocked, or communicating hydrocephalus where absorption is blocked.
Clear and structured. That gets marks. Now, Section 8, the effects. We mentioned ischemia, but the examiner wants to hear about herniation syndromes. Give me the brief overview.
Okay, there are 3 main types to mention. Subfalcine or cingulate herniation. The brain gets pushed under the falx cerebri. It can compress the anterior cerebral artery.
Okay.
Transitorial or uncal herniation. The temporal lobe pushes through the tentorium. This compresses cranial nerve the third, leading to the classic blown pupil on the ipsilateral side, and eventually compresses the midbrain.
And the kill.
Tonsillar herniation. The cerebellar tonsils push down through the foramen magnum. This crushes the brainstem respiratory centers, causing sudden respiratory arrest.
And associated with these is the Cushing reflex. This is a favorite short note. What is the triad?
The Cushing triad is a late, last-ditch sympathetic response to brainstem ischemia. 1. Systemic hypertension with a wide pulse pressure. The body is trying to force blood into the cranium against the high ICP. 2. Bradycardia. The baroreceptors sense the high BP and try to lower the heart rate.
And 3.
3. Irregular respirations.
Yeah.
Due to brainstem compression.
Excellent. Remember, if you see the Cushing reflex, the patient is actively herniating. It is a terminal event, not an early warning.
Got it.
Now, Section 9, factors affecting ICP. This is physiology. Let's talk gases. CO2.
Arterial CO2, PaSO2, is the most potent modulator we can control. It has a linear relationship with CDF between 20 and 80 mmHg. Basically, for every 1 mmHg change in CO2, CBF changes by about 4%.
So high CO2.
High CO2, hypercarbia, causes vasodilation and increased ICP. Low CO2, hypercardia, causes vasoconstriction and decreased ICP.
What about oxygen?
PO2 has less effect until it gets critical. Once PO2 drops below 50 mmHg, the hypoxic drive kicks in, causing massive vasodilation to try and get oxygen to the brain. This spikes ICP.
In patient positioning.
Gravity helps venous drainage. Head up is good.
How much?
About 15 to 30 degrees. Head down, or Trendelenburg, is bad. Also, neck position is crucial. Neck flexion or rotation can compress the jugular veins, stopping drainage and spiking ICP.
Section 10, monitoring. Briefly, what are the indications according to the Brain Trauma Foundation?
We monitor ICP in severe head injury, GCS 3 to 8, with an abnormal CT scan, or GCS 3 to 8 with a normal CT if 2 of the following are present: age over 40, systolic BP under 90, or posturing.
Good. And the methods. What is the gold standard?
The intraventricular catheter, or EVD, which stands for external ventricular drain. It's the gold standard because it is diagnostic and therapeutic. You can drain CSF to lower pressure.
But there are risks.
Yes, infection risk and hemorrhage.
What else is there?
Intraparenchymal monitors, like fiber optic or strain gauge tips. They're easier to place if the ventricles are swollen shut, but they have drift issues and you can't drain CSF.
Any non-invasive options?
Well, they're more for screening, things like transcranial Doppler or TCD, looking at pulsatility, or optic nerve sheath diameter via ultrasound. If the sheath is wider than 5-6 millimeter, it suggests raised ICP.
Good. Now the clinical meat of the answer. Section 11. Management principles. This is typically where the 20 marks come from. Structure this in tiers for me.
Right. I'll break it down into tiers 1, 2, and 3. Tier 1 is general measures.
Like what?
Positioning. Head elevated 15-30 degrees to help venous drainage, but not so high that we drop MAP and CPP. Keep the neck neutral, no twisting.
Okay.
Sedation and analgesia. We need to reduce metabolic demand, CMRO2, and stop the patient from coughing or straining. Fever control. Hyperthermia increases metabolic demand, so we must keep them normothermic. And seizure prophylaxis, because seizures massively spike oxygen demand and ICP.
Good. Tier 2. Specific therapies.
If we have an EVD, we drain CSF. Then osmotherapy.
The drug.
We use Mannitol or Hypertonic Saline. Mannitol dose is 0.25 to 1 gram per kilogram. It creates an osmotic gradient to draw water out of healthy brain tissue. It also has a recological effect. It makes blood less viscous, which improves flow and causes reflex vasoconstriction.
And the alternative.
Hypertonic saline, like 3%, is increasingly popular. It expands volume while dehydrating the brain, which is great if the patient is hypotensive.
What about ventilation in Tier 2?
We target low normal Plateau to around 35 to 40 mmHg. We do not aggressively hyperventilate routinely.
Why not? That used to be the standard.
Because hyperventilation constricts vessels. If you go too low, you cause ischemia. However,
Yes.
if the patient is actively herniating blown pupil, Cushing's triad, then we can briefly hyperventilate to a Plateau 2 of 25-30 as a bridge to surgery. It buys us about 20 minutes before the pH buffers reset.
Tier 3. Refractory ICP. Nothing is working. What's left in the toolbox?
Barbiturate coma to completely suppress metabolism. Induced hypothermia, though the evidence is controversial, it reduces demand. And the final step, decompressive craniectomy. Surgical removal of a large part of the skull to convert the closed box into an open box.
Excellent. As anesthetists, Section 12 is our home turf. Anesthetic implications. How do we put these patients to sleep?
Induction must be smooth as silk. No coughing, no bucking. Coughing spikes venous pressure. For agents, thiopentone and propofol are the go-to drugs. They are vasoconstrictors, they reduce metabolic demand, and they lower ICP.
What about ketamine? I'm going to ask you about ketamine in the Viva.
The old dogma said ketamine increases ICP and to avoid it at all costs.
And no.
Newer evidence suggests that if the patient is properly ventilated and co-administered a GABA agonist like propofol, ketamine is likely safe. But for the exam, I should probably mention the controversy, but stick to propofol as a safer answer.
Good strategy. Muscle relaxants. Succinylmethonium.
Succinylmethonium can cause a transient rise in ICP due to muscle fasciculations. It's best to avoid it or use a defasciculating dose. Rocuronium is generally preferred if we need rapid sequence.
And maintenance. Volatiles or TIVA.
We have to be careful with volatile agents. Below 1 MAC, they're okay. But above 1 MAC, they cause significant vasodilation and impair autoregulation. They also uncouple flow and metabolism, meaning flow goes up even if the brain is asleep. So what's better?
TVA, total intravenous anesthesia with propofol, is often the ideal choice for neuroanesthesia because it maintains that coupling. Metabolism goes down, so flow goes down, so ICP goes down.
And emergence, waking them up.
Same as induction, smooth. We want to avoid the wake-up storm of coughing and hypertension. We might use lidocaine or short-acting beta blockers like esmolol to blunt the reflexes. Okay, we are in the final stretch. Section 13, common exam questions and Viva traps. I'm going to throw these at you. Ready?
Ready.
Trap 1. The patient's ICP is 25. Should I hyperventilate them to a CO2 of 25 immediately?
No. That causes vasoconstriction and risks ischemia. I would only do that if they show signs of active herniation. Otherwise, I would target a Plateau 2 of 35-40 mmHg and use other methods first.
Good. Trap 2. You are looking at the waveform. P2 is higher than P1. What does it mean?
Reduced intracranial compliance.
Yeah.
The brain is tight and has no more room to compensate.
Trap 3. A patient has a head injury. BP is 80-40. Heart rate is 120. Is this the Cushing reflex?
Absolutely not. Cushing's is hypertension and bradycardia. Hypotension and tachycardia in a trauma patient usually means bleeding elsewhere, chest, abdomen, pelvis. I need to look for the bleed, not just focus on the head. Because a head injury alone rarely causes hypotension in adults.
Perfect. Trap 4. The patient is hypotensive. Should I give mannitol to lower the ICP?
No. Mannitol is a diuretic. It will drop the BP further, which kills the CPP.
Yeah.
I should use hypertonic saline or vasopressors to stabilize the MAP first.
Perfect. You dodged every trap. Now, section 14, you are writing the theory paper. You have 20 marks to get. You need diagrams. What do you draw?
I need 3 diagrams. Number 1, the pressure volume curve. I'll label the axis, the flat compensated phase, the knee, and the vertical decompensated phase.
Good
Number 2, the ICP waveform. I'll draw the 3 peaks, P1, P2, P3, in a descending pattern. I'll label P1 percussion, P2 tidal, and P3 dicrotic. I might even draw a second pathological one showing P2 being greater than P1 to get extra marks.
Smart.
And the third, the Munro-Kellie box, a simple square divided into brain, blood, and CSF, with arrows showing CSF and venous blood moving out to compensate for new mass.
If you draw those 3 clearly, you have passed the question before they even read the text. Finally, section 15,